So welcome to Epidemiology and Biostatistics, the long-anticipated, most exciting course you could ever hope to take. Just when you thought pharm was bad enough, then you get this. So my goal for this class is to not make you guys statisticians by any means. Really the goal is for you to be able to have a kind of a critical eye for evaluating the medical literature, or to have some kind of idea of what you're getting yourself into if you decide to do some sort of research. And I know that's kind of one of your components of your curriculum later on, to do some sort of research project, right? You'll come up on that. So anywho, but one of the big things that I took away, because in pharmacy school we ended up having a couple courses that were dedicated towards biostats and evidence-based medicine. And a lot of it was structured around being able to review the literature and being able to evaluate it to see whether or not what the authors were saying were actually true, and then what did it actually mean? Like, how can I apply it to my patients? And so there's a lot of crummy science out there, and there's a lot of really bad stuff that I want you guys to be able to kind of focus on and be able to find those flaws to be able to say whether or not this is going to be applicable to my patient or not. Right? So that's kind of the goal I'm going from. We'll cover a lot of the concepts and how they're used in the medical literature, and I'll probably give some colored commentary here and there, at least what I see in day-to-day practice. So the way it's going to be structured is we'll have some lectures. I'm not going to post the schedule yet because I got to figure out how to fit everything in since this is my first time teaching this course. We're going to have 2 workshop days where basically that will involve breaking you guys into groups and doing some literature evaluation. So that'll be done, basically the course is kind of divided half into biostats, half into epidemiology. So we'll do that basically on the 7th class of each one. And then there'll be 2 tests involved, one for biostats, one for epi. And then those will both be about 30% of your grade, which is it's in the syllabus. And then 40% is going to be participation in that group work on those 2 days. That make sense? So shouldn't be too bad. I haven't looked at the test yet, but there should be some good tests. So anyway, I hear you guys like my test anyway, so just kidding. Okay, so first thing we're going to do is talk about our introduction into statistics. Has anyone who's taken statistics before? Okay, so most every, I thought it was like a prereq at least at some point for you guys. Who feels super confident they could discuss statistic concepts right now? Oh, so do you want to get up here and start teaching with?
Standard deviations. Medians.
Median. Okay, you got it. Done.
Let's take the test.
Okay, ready for the test? No, okay. So we'll go a little bit more in depth in that, but we'll focus a lot on things like statistical tests. Does it make sense for the type of data that we're looking at and how it's applied to the medical literature? So I'm going to start from the ground up for you guys, just to make sure everyone's on the same page. And if I say anything that I say it with the like you guys know what I'm talking about, and you don't, just pipe up and interrupt me. I'm more than happy to try to define something or talk about it. So anyway, right now we'll do our quick introduction. We want to be able to delineate some of the reasons why stats and probability aren't really intuitive to people, especially when reviewing medical literature just kind of at a glance. You never want to be that type of clinician that makes a decision for a patient based off reading an abstract, right? Never want to do that. It's bad practice, right? Because there's lots of bad things that can show up in the abstracts, or not enough information. We want to, show you guys how to overcome some of the obstacles that makes statistics so hard to learn, which we know definitely is lots of abstract concepts we'll talk about, and then look at some of the applications and the terms we're going to use to discuss statistics and probabilities in regards to a sample population. And as you know, statistics, 60% of the time is going to work every time. Right? And so to at least drive the point home, I want to show you guys an example in my actual real life of how I was able to use a critical evaluation of the literature to better suit my quality of life. Okay, so for instance, there's a time where my now wife, we were engaged and we were both looking to move to Orlando, and I said, well, we should just move in together. We have one house instead of 2, it's perfect. And she goes, we can't do that. We're going to be more likely to have a divorce if we move in together. And I said, well, what's your source on that? She goes, Cosmo. Cosmo says we're more likely to get divorced if we cohabitate. And I said, no, that can't be right. Cosmo, they don't do rigorous statistical modeling and all these things. There's got to be something else there. So I decided to look it up. Sure enough, the CDC had this wonderful study looking at cohabitation and divorce rates. And I said, well, this is perfect. Let me see what the actual data really says. because, you know, CDC versus Cosmo, I'd probably take the CDC at their word. Usually, most of the time, unless it's like makeup advice or something. So anywho, so what they did find is that yes, if you cohabitate, in general, they saw higher divorce rates. But what the interesting thing was is that the men who were, because they're just looking at the male component of it, they were saying that 71% of those were divorced at 10-year mark if they were engaged prior to cohabitating, versus 69% who had not cohabitated beforehand. So that's only a 2% difference. It's not that big of a deal, right? So I showed her the evidence, and sure enough, she finally conceded, said, you know what? Let's move in together. So that way, basically, I saved a lot of money. We figured out if we're going to kill each other prior to getting married. So everything worked out great. So I'll tell you guys in 7 years whether or not we're still together, and we'll figure out the data actually bears out. So anyway, so actual real-world application for some of this stuff. Okay. So why are people bad at statistics? We tend to jump to conclusions very frequently. It's very easy to look at a small sample of data and try to generalize that out to the whole population, right? We'll talk about samples and populations, but it's really easy. If I were to look at 64 PA students, can I generalize everything about you guys out to every single PA student in the world? Maybe some things, maybe not. It just depends on what the information we're looking at. But you wouldn't want to use all that information with small data sets to generalize to a whole population, right? Because there's just a lot of inherent risk in doing that, which we'll get more into details on. So you really need to look at using statistical rigor to help avoid making overly strong conclusions about the limited data that you have. And so we'll talk a lot about the term generalizability, and that basically is going to be referring to looking at the data that you have and those results and how well you can apply it to the population. Right? And so some things can be very generalizable, some things cannot be generalizable based on the type of data you're getting, the results you're getting, and how that stacks up compared to the population that you want to be looking at, right? So population just doesn't mean that of the United States, but it could be a population of, say, PA students, it could be patients with HIV, whatever the population you define it as, how well that data that you have from that small sample, how well it applies to them. So we typically, as human beings, we're very good at seeing patterns, especially where ones don't exist. So if you imagine, this concept of hot hands in basketball, where if you get one basket in, you're more likely to get the next subsequent baskets in. And so that was a popular thing that people thought for a long time. It's just like if you see a blue car, all of a sudden you see nothing but blue cars after that, right? And so they're actually looking at some of the data out there and found that there's actually no correlation between that. It's all 100% random, basically 50-50 whether or not they're actually going to make that shot. So just to give an example of a graph that kind of shows that, there's a table here where you're looking at 10 different basketball players and basically looking at 30 different shots that they had taken. So an X would be it was a success, and a negative is going to be a miss here. And so if you're looking at it, does anyone see a pattern? Because your mind kind of gravitates towards like, oh, the guy got 5 shots in a row. That looks like a pattern, right? Well, if you actually were to do the statistical test, you'd find that it's, basically there's no actual pattern here. It's just random chance. And so we're going to be looking a lot at random chance and how well the data that we're seeing or the results that we're seeing, could those just be due to random coincidence, or are they actually statistically significantly different than that? Isn't just chance of doing this. So that's some of the things we're going to be looking at with this course. So again, that table is 100% random. Basically every shot was 50-50. No previous shots did not necessarily inform future shots being made, right? All of it had to do with just whether or not the player made it. Just like flipping a coin, obviously if you were to flip a coin 100 times, are you guaranteed to get 50 heads and 50 tails? Probably not. But if I had all of you guys do it, I'd probably be more likely to get to an average where it's closer to 50-50, right? So same thing's happening here. As you increase your sample size, you're getting a better idea of what the actual true mean or the true average of a population is by increasing your numbers. If I were to look at just n of 1, right, and n is typically what we're going to use to denote the number of observations we're making. If I just have an n of 1 person doing it, you're unlikely to get anything close to what the actual population average is. But if I use a lot of people, a larger n, you're more likely to get closer to that real average. So even knowing that something's random, it's really hard not to see patterns anyway, because our brains are really naturally evolved to do that. And so that's why it's so important we have to use statistical rigor, not just use anecdotal evidence, not just what you think is happening, take it as fact. You need to really do the actual studies and you need the data to make those kind of decisions. So coincidences are exceedingly common in medicine, certainly. Just because I give a drug to a patient and all of a sudden they're reporting better pain scales, is it necessarily that there was a causation there? Right? Probably not 100% of the time. So again, correlation does not mean causation, even though our brains are kind of hardwired to find those type of patterns. But just realize those coincidences are common, and the idea between doing these tests, these statistical tests, are to make sure that the things we're seeing are not just coincidences, but actually true differences between either treatment groups or looking at differences between different populations for some sort of outcome. So, for instance, if you were to look at, people have a tough time with probabilities, especially when you're faced with just the numbers. So, for example, say you had 2 bowls of jelly beans, one small and one large. And so, say you were to have one that had 9 white jelly beans and 1 red. The other one had 93 white and 7 red jelly beans on it. And you were to get a prize for picking the red bean. Which bowl would you go for? So, who would go for the first one, the 9 white and 1 red? Okay. Who would go for the other one? Who would abstain from ever picking a jelly bean in the first place? See a lot of hands. Okay. So looking at your chances of it, what do you think? So what are the chances of picking a red one out of the first bowl? 1 in 10, so it's 10%, right? Versus the 7 versus 93, what are your chances? 7%, right? So looking at that, people may incorrectly decide, well, there's more red ones. Obviously my chances are improved, right? There's 7 of them versus 1. So people have a tough time with that, especially lay people when looking at numbers like this. They'll kind of make the illogical choice in a lot of cases. You can see this very frequently, especially when looking at report outs of data. So if you were to look at whether or not they thought a cancer was more risky, looking at 1,286 patients out of 10,000, they thought that sounded much more risky than 24.14 out of 100. Even though which one's more risky? Yeah, the second one, because it's twice the risk there, even though the numbers are smaller. It's just all a matter of how you're reporting it. And so a lot of people can look at those numbers and not really make good logical decisions about that information. So again, that's why it's always it's very easy to lie with statistics in a lot of cases, and kind of change the way you're exposing the information to allow people to reach kind of not great conclusions. So another example, going back to our jelly beans. So say you had 2 urns, each of them had 100 jelly beans in it. The first one has a mix of 50 red and 50 black. And then the next one has an unknown mixture of red and black. You have no idea what the proportions are there. And you get a prize for picking the red bean. Who would go for the 50-50 jar? Okay, who would go for the other jar? You'd have to see. So what are the chances of pulling it from the unknown proportions? You don't know, but at least you have a 50-50 chance for the first one, right? What if it was like 99 red ones and 1 black one? You had much better chances at that point, right? So because of this kind of ambiguity, because you don't have that information going forth, it's much easier to make that decision to go with the 50-50 jar, just because you know what your options are, what your chances are. But in a lot of cases, you might be better off going with the unknown one, just because it could be totally in your favor. It's hard to say, right? So again, when they did this, it looks like almost everyone went for the 50-50 jar, just because they know the numbers. They like to play the safe game in that situation. So in that case, if you were to go with the unknown proportions, you're randomly likely to pick either black or red in that case. And so in some cases, your chances might be actually better with going with the unknown. So again, just to kind of give you examples of how people don't like thinking about these ambiguous situations, like to have all the data. And a lot of times when in the medical profession, we don't really have all the data in a lot of cases. And so you have to go making decisions off of not having the full picture. So again, just kind of talking about what we were looking at here. This is another good example. Has anyone heard of the Monty Hall problem? Oh, you're just talking about this? What is it?
The Doors.
Yeah, the Doors, right? So not the band, the Doors, but
I just found 2 doors, there's a prize behind one. You eliminate one of them, you still have a 1% chance.
Is it better to switch?
Yeah, so the question is it better to switch doors or not? So should you switch doors?
Yes.
No? Yes? You should always switch doors. Should always switch doors. So essentially, yeah, so you have 3 doors, one of them has a prize. The person eliminates one of the doors that had no prize behind it, and then your task is deciding whether or not to switch over to get your prize or not. And so if you were to actually look at it, because people have a tough time actually going through and working out the math of it, especially in their heads, especially under pressure if you're on a game show or something, you'll find that you actually, if you were to switch your options or switch, change the door you'd picked, you actually have a 66% chance of getting the prize, because 2 out of 3 times you're going to actually switch over to picking the prize, versus if you were to stay, you're more likely to get nothing at that case, right? So just kind of interesting thing. A lot of people don't. It's not super intuitive to think about it this way, but in a lot of cases, people still will make the wrong decision and say, okay, I'm going to stay with this door and go with that, right? Does that kind of make sense? So if you look at in the first circumstance in option 1, so you already chose the prize, right? Like your hand's already on the diamond. You don't know that yet, and so they eliminate one of the ones that has nothing on it. So if you were to switch, in that case, you would actually switch off of the prize and you'd be SOL, right? The other 2 circumstances, though, if you were to pick ones that had no prize underneath it and they were to eliminate the other one, in both of those circumstances, you switch over to actually pick the prize. So 2 out of 3 times, you're making the right decision, and that 33% of the time, you're not going to get anything, right? So your chances are actually better than if you were to just stay with that same option the whole way through. You only have a 33% chance of actually getting the prize.
It doesn't work on your test, though.
It doesn't work on my test, it's true. It's because I'm not there to eliminate the false options. Touché, sir. So anyway, point is, and just like on my test, guessing is hard. Okay. So again, your best choice is to change in this situation, but again, a lot of people are going to not be able to kind of work through those multiple processes and come to the right decision. So looking at some other things, so has anyone heard the term Bayesian statistics or Bayesian calculations? So this is basically, we won't talk too much about it in this course, but this is an idea where you have some amount of information going into some sort of question that you have, and using that information and using new data that you're finding out by doing the test, you can make certain inferences. So in this situation, we're going to be looking at HIV blood screenings. And so say in a normal healthy population, the incidence or the prevalence of HIV is pretty low. So we'll say in this circumstance it's 0.1%. Okay, so these are just some assumptions we're going to go into the test we're talking about. So we want to do a new antibody test. We know it's pretty accurate, but it's not quite perfect. So it has about 99% sensitivity. And what does sensitivity mean?
It's going to pick up all positives.
Yeah, so it's the ability for the test to actually detect the positive results, right? So it's about 99% sensitive, which means that 1% of true cases of HIV won't be detected, right? So it's pretty good, but not 100%. And then specificity, 99% specificity. What does specificity mean? Yeah, so it says that if you have a positive result, that it's actually a true positive, right? And so it's 99% specific as well, which means that 1% of the people that show up positive don't actually have the disease, okay? So going into that, what are our chances of a true positive versus having a false positive? And so say we're looking at a normal, healthy population of individuals. We're going to test 100,000 people, okay? And we know that the incidence going in, based on population data that we have, it's about 0.1% will have HIV, right? So going in, we know that the test is going to be positive for 99 of them, right? Because we already know that the incidence is 100 for this group. So that means that 99% of those patients will be detected with this test, okay? So then you test, obviously you're testing everyone in the subset. So the other 99,900 obviously do not have the disease, but you will see 1% of them being tested as positive incorrectly, right? Because that's that specificity we talked about. So that means you're going to have 999 false positives. That's not so good, right? It's telling almost 1,000 people they have HIV and they don't. Not good. So when you actually combine that and you're looking at the positive results, you only have about 9% true positive rate for this test. So would you think that's an actual good test? Probably not for your purposes, right? You probably want some more confirmatory cases. And this, in this situation, we're looking at this population, 91% of the positive results are actually false positives. So again, that's not such a good thing to do. But if you were looking at a different population, say we're looking at a group that has a higher incidence of HIV. So anyone can think of any populations like that?
Washington, D.C.
Washington, D.C. Okay, maybe not places, but maybe let's just go with IV drug abusers. Say that's what we're going to look at. So anyway, so again, if you as a clinician, if you were to get a positive result back, you're probably going to think that patient does have HIV, right? And so, but it's important as a clinician to really take into account all of the different factors that go into this. So remembering things like the prevalence of HIV, and knowing that if you're working in a place like Washington, D.C., you may be more likely to see it versus if you're working elsewhere, So say we're going to do this test in IV drug abusers, who we know they're a high-risk population, higher incidence of HIV in that group. So say we test 100,000 IV drug abusers, say across the country, and so with them, instead of having, say, a 0.1% incidence, here we're going to say they have a 10% incidence of HIV. Okay, so 10,000 of them we know going into the test have the disease. So for them, you get 99%. Ability to detect the positive results. That's 9,900, and then for the other 90,000, none of them have the disease. And so, because we said the specificity is only about 99%, you're going to see it incorrectly returns a positive rate in 1% of cases. And so here it means you have 900 false positives. So when you actually look at the true positive rate, it's about 92%. So again, based on the population you're looking at, having a positive result in this test means something totally different, right? So in which case, if you have this group, maybe you don't need to do confirmatory testing because you're much more likely to have really gotten a good result on that first one versus the otherwise healthy population. So just to give you an idea of how looking at these things and how you can imagine reading the results in the literature, you need to really look at it with a fine-tooth comb to find out and suss out these kind of details. So again, in the case of here, when you're using these Bayesian statistics, it's important to remember to incorporate the existing data that you already have. So that's that population data and the incidence of HIV versus the new data that we're having coming in to compare it to. Another thing you have to be really careful of in the medical literature is multiple comparisons problem. So as an example of this, they did a study where basically they were looking at health statistics for 10 million residents in Ontario, Canada, and basically they just mined it for data, right? So this is a common thing to generate hypotheses where you can actually go through and mine databases. And what they wanted to do is they looked at 223 different reasons for hospital admission, and they wanted to see if any of those compared or had any relation to their astrological sign. So say if you're a Scorpio, you're more likely to have a head injury to be admitted to the hospital, right? Those are kind of the things they were looking for. And so what they actually found was that 72 diseases occurred statistically significantly more frequently in one astrological sign than you saw in the others. So does that make sense? Is medical conditions linked to astrological signs?
Doesn't make sense.
No, they don't, right? So we know there's really no good relationship between astrology and health. So again, when you're looking at this, and we'll talk about things like confidence intervals, we'll talk about things like power, and when I talk about p-values, what's a p-value mean?
Statistical significance.
Okay, so it's testing for statistical significance, and what's a common p-value you always hear of? Yeah, 0.05. So we'll talk about where those numbers come from and why a p-value less than 0.05 is important. But basically that just means that the results that you see in the data you're looking at, that less than 5% chance that it's just due to random variability, right? So that means you're 95% sure that the results you're seeing are actually true and not just due to random chance. Okay, so if you're looking at this many comparisons, if you're comparing all these different 10 million patients who are being admitted to hospitals for different things, and you'd expect at least 5% of the time you're going to find some kind of statistic significance there. And so in this case, you would expect to actually find 134 just by chance alone. But when in actuality, you actually end up having even less than that being linked as being statistically significant. So this is one of the things we'll talk about later on, and it's very common for to do multiple comparisons and not really be able to correct for those p-values, and you end up having kind of false positive results, right? So you say that there's definitely a relationship here when actually there probably is none. You just did so many of them that you kept doing them until you found the one that worked, right? So it's another thing that that's very common in medical literature that we'll look at ways to avoid that. Does that make sense? You guys. So again, if you crunch the numbers enough ways, you're eventually going to find something just by chance alone. And we'll talk about why those numbers, where they come from, but just realize that just because something is statistically significant doesn't necessarily mean anything, right? we tend to ignore alternative explanations for some of the results that we see in our data. So say, for instance, we were doing a study, we're looking at acupuncture for osteoarthritis, and then they went ahead and had the subjects, they were asked for the rate of arthritis pain before and after the treatment, right? So that sounds like it's pretty easy. What are some ways you could rate pain? 1 to 10.
Sad face to happy face.
You do the faces. You can take a visual analog scale, which is like, a 10 centimeter scale, and you can just kind of point at where your pain is. And when they did the test, when they did the study, they actually found that pain decreased in most patients, right? So when they did the statistical calculations, they saw consistent findings that were exceedingly unlikely to be by chance alone, which means that it was statistically significant, right? So the acupuncture must have worked, right? Not necessarily. It all depends on how you're actually conducting your study. So say, for instance, there is a true thing as a placebo effect, right? So what's one way you could avoid a placebo effect? So I heard control, right? So you have a control group, right? So you have maybe a group of patients that gets acupuncture versus one that doesn't, right? So that would be able to control for some, well, hard to say that because, again, you're getting poked by needles. You kind of know whether you're getting poked by needles or not.
Like poke them with like a ruler when their eyes are closed.
There, perfect. Yeah. So you have some kind of dummy device that would do it, right? So you're not actually piercing the skin, but something that will simulate it, right? For instance, when we do some of the investigational studies we do at Nemours, we're using a drug. Has anyone heard of SMA, or spinal muscular atrophy? It's a really debilitating genetic disease that happens to certain, small number of kids. But basically, the muscles just atrophy over time. They end up dying from respiratory failure usually. But there was a new trial drug we're using. We actually would inject the drug intrathecally, right? So that's one of those situations where you want the patient to not have any idea, because there were some that were getting control drug, which was no drug at all, and then some were actually getting the actual test drug. And so the only way to really fake an LP is to actually just give them an LP, right? So that's what we'd have to do for those patients. And so they said they would just get saline put in instead of the actual drug. And that way you kind of make sure that the patients don't really know what they're getting or not. And really the only people that do know are going to be the research coordinators. So that's a method of blinding that helps to remove some of the biases we'll see in these things. Is there any question?
The other group, so the control group in that study gets no treatment?
Yeah, so because this is an experimental drug, we don't really know what the efficacy of it is. They were getting nothing versus this new drug. And so in that way you kind of avoid that placebo effect of like, okay, well, I had a shot down in my back, I feel better now. You kind of get rid of some of that placebo effect by having a control group there.
Is that ethical? I thought you had to do it the current gold standard of care versus your new experimental treatment.
Mm-hmm. Right. So in this case, this is a disease state that really doesn't have a gold standard of treatment. Right. This is just it's an orphan kind of indication. There's very few children that actually get affected by this, and so it's one of those things where these are like some of the first new treatments that are coming out for it that we can actually help to hopefully see some reversal of the effects. A lot of it's kind of like genetic therapy kind of targets. So you're right, in a lot of cases, it's like withholding HIV drugs from HIV patients, right? You can't do that, right? Because that's not ethical. But in this case, if there is no standard of care, you're trying to find out if this drug is actually efficacious in the first place, then you're okay. Yeah, but very, very good question. Ethics come into a lot of these cases. In a lot of cases with tox, clinical toxicology, we can't do good studies, right? Because I can't, take a Eastern Diamondback and inject a bunch of people with the venom and then be like, okay, you get anti-venom, you don't. See how it does. You just can't do that. So a lot of times you end up having kind of substandard research you're looking at things that don't really help give you a clear idea about causation or anything like that. So we'll talk more about that later. But again, if you're surveying patients, sometimes patients just want to be polite and they're like, oh yeah, sure, I feel better after the person stuck me with 24 needles. Perhaps they were doing other things that you did not control for, right? So if they were started taking say Motrin at the same time they started this acupuncture therapy, and you never accounted for that, so that's something known as a confounder that can skew your data. Say you were excluding patients for having worsening pain for any sort of reason, like that could skew your data if you're starting to censor patients out. And then looking at things like pain just kind of vacillating from day to day. We'll talk about this idea of regression to the mean just a little bit. But in some cases patients may have really bad pain one day and then they just naturally get better because they're at some extreme of it. That kind of makes sense? So lots of reasons why some of the results that are statistically significant might not actually mean anything. So regression to the mean is this other idea, which we kind of just alluded to, where things of extreme natures tend to go back towards the mean over time, or the average value. So again, I'll show you a picture on the next slide that actually shows some before and after values of blood pressure. And so looking at it, say we instituted some sort of new drug, some sort of new antihypertensive to affect the blood pressure. And so if you actually look at the data, if you just look at the kind of the cumulative data here, and you see that line going across, that's the average, right? So for all the data there, it's showing the average before values on the left, after values are on the right side there. If you look at them, could you say that that drug had any effect on blood pressure? Looks kind of scattershot. It's kind of hard to say, right? You can't really make any conclusive assumptions just based on that first graph. If you were to take just the top half of values, what do you notice with the treatment then?
Generally goes down.
Tends to go down, right? But then if you look at all the bottom values, what do?
Tend to go up.
Yeah, so everything kind of tends to go back to the mean, and so that's why we talk about, especially with talking about our p-values and things, in the null hypotheses, and saying that is it just random coincidence that we saw these changes, or is it actually due to the intervention that we did, right? And so that's where a lot of this comes back from, is that because things tend to regress to the mean, it's very, very frequent that coincidence is just the result of the results that we're seeing, okay? And so usually you'll find studies that are being done, and this is why we do the statistical test, to show that it's not just coincidence, there is a very high chance that it's actually due to our intervention. So again, patients with any kind of extreme value tend to go back to the average, just due to natural changes over time. So say you were to get someone on Monday have extremely high systolic blood pressure, you may see it go down over time. It's not that you did anything; it's just that it's going to be regressing back to that mean. So does that make sense? Okay. Okay. So why are stats so hard to learn? That was kind of a funny picture. Okay, so lots of obstacles. First one going to be fear of math. Who's scared of math? Yeah, ditto. We're not going to do a whole lot of math here. I'll show you some of the math, but just keep it at arm's length. Don't actually have to know how to do it. Just we're going to talk about, though, the values that go into figuring out how we get some of these statistics that we're going to be looking at. We're going to also look at the issues of confusing terminology. You guys are definitely used to that if you're gone through pharmacology already. There's also issues with abstract thinking, and then looking at probability versus certainty in stats. So we'll talk about each one of these in more detail. So, like we said, it's if you ever look up a statistical test, or if you ever look up any kind of stats term in Google, and you go to the Wikipedia page, it is very confusing. Because again, you get all like the proper nomenclature for how they actually do the math behind all this stuff, and it's really, I just wanted to know what this test is used for. But it's really made for statisticians, and so since you guys are not going to be statisticians, I'm going to show you at least the bare minimum you need to know in assessing whether or not this test was actually appropriate for the type of data they're looking at, or is it inappropriate based on what you're seeing. But we'll look at the different variables and how that actually comes to be figured out. But really, as long as you know some basic algebra, you can usually get through most of the medical literature without too much trouble, right? Because most of the time, who's doing all these calculations? Computers, right? They have nice programs like SPSS that can do all this data for them. So I'm sure most of the statisticians could tell you how to do it, but they probably don't do it in their head. A lot of computers are being done to come up with a lot of these graphs and the values you're getting there. So just like you don't need to know how a point of care testing glucose monitor works, you just need to know what the glucose is. This is similarly how we're going to be looking at biostats. Make sense? Okay. There's also lots of confusing terminology, so we'll talk about definitions as we go along. Again, if I ever say anything that doesn't make sense, please interrupt me so I can talk about it. But here are some of the things that we'll look at as we go through the semester, or the rest of the semester. So looking at things like significance. What does significance actually mean? Look at things like errors, hypotheses. So if you see these come up, make special note of them, highlight them. Probably will come up later on for testing purposes. And this is just kind of the natural jargon you need to know in order to help to discuss these things intelligently. Also keep in mind that just because something means, so like when I say like the term normal in statistics, it's not going to mean the same thing as normal to like a normal person, right? So just keep in mind that sometimes in biostats you're going to have words that don't necessarily have the same meaning as you would apply them to say like a human being, right? So other things we're looking at, the goal of statistics is to analyze data, and we want to make conclusions, right? So it sounds like it's a pretty concrete thing, but the issue is that we're trying to take this data, usually small subsets of data, and try to apply it out to a larger population. And so that may not be quite as concrete, right? Because we run into issues of generalizability. So when we're looking at these things, remember that we're looking at populations. Remember the issues that comes about when looking at probability distributions and also the null hypothesis. We'll talk more about those in details a little bit later on. But just realize that sometimes you're making kind of abstract conclusions about a set of data that you have to apply it out to everyone. And then probability is being shown here, never certainty, right? So you always want to be really, really critical of anyone that says that, this drug 100% lowers blood pressure. No, you have data that says that it appears that when patients take this medication, that their blood pressure lowers. You never want to necessarily ascribe 100% causation to any of the data that you see because you're really just seeing probabilities, right? And there's always a chance that it could just be due to random chance, right? And so we're going to be looking at that and how these numbers come about and statistical significance and comparing that with clinical significance as well. So just keep that in mind. Stats is basically just never having to say you're certain, but at least saying that, probably this is right, but who knows, right? So just like I mentioned with that CDC article, I probably don't have a higher chance to get divorced from my wife, but I tell a lot of bad jokes. So, that may be a confounder that the CDC didn't really count for, who knows? So like I said, we'll see in 7 years. Okay, so the next thing we'll look at is going to be kind of going from samples and comparing those with populations. So again, when reviewing statistics, know that samples and populations are going to have a little bit more distinctive meaning. We're going to look at a few different circumstances and where these can be applied to different situations. So here's the 4 here. We'll talk about them a little bit more in detail. It's nice and timely that we're talking about political polls, right? Everyone seems really excited about the election. Okay. So you guys are too busy studying to go vote, right? So the first thing we'll look at is quality control. So in this circumstance, say we're looking at what would be our population if we were doing quality control on something? Anyone think of like an example?
Medication, drugs.
Oh, that's a good one. Okay, so say you're producing medications, say you're producing tablets, right? And so your population would be all the tablets you're making, right? So what would be your sample?
Individual ones that you picked out of there.
Yeah, so a certain subset of those tablets you would take, say, out of every 1,000 tablets made, you're going to take 10 out of that group, and you can test them for things. You can test for the actual drug content in there. You can look at things like solubility. You can look at different factors about it, and by using that sample, what do you do with that data? Or how do you apply it back to the population?
You presume that the sample was the same.
Exactly. You presume that sample you took is representative of the entire population. So you can say that, well, these 10 were good. I'm going to assume that these other rest of the 1,000 are good too. Okay? Sounds pretty reasonable, right? It's kind of like, when you're going through like checking cookies and make sure like no rat particles got into it or stuff like that. So again, quality control can apply to anything like that. But again, you're using the sample data to apply it back to the population to make those generalizable, or to make that more generalizable. Okay? So you can see how this might be more difficult with people.
Right.
Right. Because people aren't just cookie cutter tablets. They're going to be very, very different from one to another. Most of your patients will end up being snowflakes to some degree. But again, in this case, it's very generalizable because it's all going through the same process. But in some cases, say you were looking at blood pressure treatment with the medication, and so you look at a subset of people. Say you look at 1,000 people that were randomly picked. You saw good results with that. Well, if your patient has something different about them than that wasn't represented in that sample, then it might not be generalizable just because they had those inherent differences. Another example would be like political polls. So say you're doing a random sample of voters being polled about who they're going to vote for president, and then using those results to make conclusions about who's going to be the winner, right? So what are some inherent problems with that?
Small sample size.
Good, so small sample size. So maybe only doing like 30 people versus how many people vote in the general election.
Millions.
Yeah, millions, right? Good. What could be some other issues?
Locality.
Yeah, location, right? So if I do it here in, say, I was to do it in St. Cloud versus I were to do it in, downtown Orlando, maybe those results might be a little different, right? Versus if I do it in, say, Seattle versus Orlando, those results might be different. So locality can be a big thing there. So again, generalizability can be very a big issue, even with something like doing these political polls. There's a good example we'll talk about later on in the course where looking at political polls and making those extrapolations are actually kind of a famously bad example of doing that. Then looking at clinical studies, we already talked about this. So obviously, our population here is going to be kind of what we define it to be. And so you'll see that defining populations is really important when looking at clinical studies. So say, for instance, you're looking at, the tolerability of, say, HIV medications. Who's your general population you want to kind of extrapolate that data out to?
HIV population.
Probably all HIV patients, right? So you're not really looking at a certain subset. You're not comparing it to all healthy people as well. You're maybe only be looking at certain HIV patients. So when you are pulling people to participate in your clinical trial, you want them to be a random sample of that, right? And why is the random nature of that so important?
So that you can generalize your results.
Exactly, right. So if I start to cherry pick things, so if you imagine if I were to start going through and looking at say we're to pull patients who are only coming to this specific clinic for my trial, what are some problems with using those patients as a random sampling of my larger population?
They've self-selected, so there's something special about them already.
Right, so maybe like they're more prone to having good follow-ups, and maybe they're more compliant with medications versus patients who have no follow-up whatsoever. Like you maybe not be able to generalize out to that population as well, or homeless patients or things like that. So look at those kind of biases and look to see like where they're getting their patients from, how are they randomizing things, and is that generalizable to your patient group, right? So keep those kind of things in mind. So again, in a lot of cases, you'll still find some utility in extrapolation, but you always have to take everything with a grain of salt. Just to remember that there are going to be a lot of confounders you're not going to be able to really control for, because again, all patients are going to be a little bit different. In laboratory experiments, you can also kind of use these ideas here. The population is kind of more of a there's not really a good definition for that necessarily in this case, but a sample is usually where you're taking samples of data and trying to apply that back to hopefully it's going to be representative. So I guess like the best example of this, if you're doing like quality control tests for say like point of care testing and things like that, so say you're doing your control solutions for say a glucose monitor, using those solutions in order to help you know what your known data is, you know what that sample is, and hopefully that your test is actually going to get the correct value, right? So a little bit looser definitions there, but just know that you can use sample and population in different ways depending on how you're applying the data. Okay, so it's important to know what stats cannot do. They certainly have some limitations to them. And so ideally, if you were to run an experiment, say you wanted to find out whether a new medication was effective for, say for cancer, ideally what you'd want to do is one, define your population you're interested in. So in that situation, who was your population? Say for breast cancer. So there's breast cancer patients, or it could be more specific. So you imagine like certain medications we talked about in the hem-onc section were better for patients who express certain receptors. So maybe our population is patients who only express certain types of receptors in this particular breast cancer. Okay, so your population can change, and that's why it's important to define that. And then after that, you want to randomly select your patients out of that group, right, to make sure that you're getting a group that is generalizable to that larger population. So you want that sample to be that way. And then ideally, you could do a control group, right? So you want to split your group in half, and half of them would get treatment, and half of them would get the control, whether it be the standard of care therapy, or whether it be nothing, placebo, whatever happens to be. In a lot of cases, you'll see that for like certain oncology studies that we do, say at Nemours in the children's oncology group, sometimes it's like changes in dose. So you may see like this is the high dose ARC regimen versus this is the standard dose regimen. So sometimes you'll see even changes like that. And then you would want to measure typically, ideally a single variable in each subject. So what might you imagine one of those things you can measure for that patient?
Tumor size.
So tumor size. What else? Like death could be one thing you can measure, right? You might want to measure, life expectancy when receiving the drug. Those are all kinds of different things you can look at. It could be quality of life. You could, whatever measurement you want to be looking at for this group, and then you make those comparisons using statistical tests to find out whether or not those differences that you see between the groups are just due to random chance or it's actually due to your intervention. And that's where we'll do those tests to find the p-values and find out whether or not they're statistically significantly different or not. Because again, we know that by picking random subjects out of a population, if we see changes, a lot of times it could just be coincidence. But by doing those tests, we can make a better idea of whether or not there's an actual difference and decide whether or not there's an actual effect with the treatment. So a lot of times you'll find that scientists or people running these studies are going to run into problems that kind of limit the validity of a lot of their statistical reasoning. if you were looking at, obviously, we can't do a lot of placebo-controlled trials. There's a lot of populations we can't do studies with. So if you imagine some like protected groups, like pregnant patients, like those are very difficult trials to do. A lot of times you just can't do them. Again, ideally, you'd want your population or your sample to be the same exact group as the population, right? But those numbers are always going to be impossible to get, right? You can't give every single person in the U.S. a drug to determine whether or not it's effective. So again, you're always going to be making some generalization of the data you have using limited numbers. And then again, looking at your measures, if you wanted to look at life expectancy, the inherent difficulty with that is that what?
You don't want your patients to die?
Well, it takes a long time to determine life expectancy, right? So potentially, unless you have a study going on for years, which in some cases you do, that might be a problem, right? So say, for instance, if it was like a really aggressive tumor, say you were doing like with like lung cancer or pancreatic cancer, like that might not be such a long time you're looking at necessarily to show differences in survival rates. But for like, say, prostate cancer, like that has pretty low mortality rates as it is, that would be more difficult. So again, sometimes you're looking at surrogate measures in order to get an idea. So we'll look at some examples of that in a second. So again, realistically, you're going to be looking at subsets of populations. So for instance, we mentioned, if we're doing an HIV study, you may be only having HIV patients who are aged 20 to 40 who live in San Francisco, who've come to a university clinic. That's a very specific subset of patients that may or may not be generalizable to your whole group or your whole population that you're looking at. You also have to look at things like exclusion criteria, like perhaps the patient you're trying to make a treatment decision about would have been excluded from that trial anyway, in which case you can't really use that data to say anything about your patient, right? So if an HIV patient was too sick, say they had some say like PCP pneumonia or something else that made them too sick to participate in the trial, and your patient's like that, you won't be able to make those good generalizations there. Other things you're going to look at, like surrogate measures, would be, for HIV patients, looking at CD4 counts, right? Because that's usually a pretty good surrogate to determine their kind of disease progression and how likely they are to survive. So obviously, higher CD4 counts, the better. And then again, you're using that data to extrapolate out to a larger population, which may or may not work. So. And again, in a lot of cases, you may be using one intervention in order to tell, to look at a lot of different changes. So say, for instance, you're not only looking at CD4 cell counts, but you're also looking at reduction in medical costs, side effects, increased quality of life. And if I keep doing these different comparisons, what do I run into a risk of? So it's that multiple comparisons problem we talked about earlier, where if I keep running a statistical test over and over again, eventually I'm going to find something by random chance. And so that's why in a lot of cases you need to make sure that the studies are disclosing whether or not they actually did any kind of control for that. And so there's certain tests you can do or certain things you can do to make it so that you're less likely to make those kind of errors, right? So just be aware of that. Be aware that the more transparent a paper is, the better you're going to be able to determine whether or not it's going to actually be valid for your patient. So again, some issues you can run into. So say, for instance, your population that you really care about is more diverse than the population sampled. Again, that limits your generalizability. If say your subject were not randomly sampled from a larger population, say if it was like a self-selecting group, like ones that were responding to an ad because they saw there was pay involved, right? So you hear a lot of those radio ads for come try this new psych med. If you're getting paid for something, you might be a little bit more likely to comply with that, right? So again, that may skew some of your data. Again, looking at whether or not your measurements are actually done correctly. So in a lot of cases, if the measurements aren't done well, that's going to skew your data to maybe show you results that are erroneous. And then again, looking at making clinical outcome or clinical decisions is going to be really important to determining, with the study, the data you're looking at actually showed what you're wanting to compare it to. So for instance, if you're trying to look at quality of life specifically, and in your patient you're more worried about mortality, you got to make sure you're comparing apples to apples. Again, stats are never going to be 100% certain about anything. So again, everything, there could be a small percentage chance that it's just due to a random coincidence. So if anyone ever says something is 100% sure, always take it with a grain of salt. You're going to hear a lot of things like probably, most likely, almost certainly, but really it's hard to say this is absolutely 100% true. Because again, we're just looking at probabilities, we're just looking at relationships. Very rarely can we ever say there's actual causality happening. So. And just because something is statistically significant does not actually mean anything, right? So if I can see that a drug that costs 10 times over what standard therapy is, statistically significantly drop blood pressure by 2 points, Is that clinically significant? Probably not, right? So you can say statistically significant all you want, but unless it's clinically relevant, it doesn't really matter. So again, that'll be something we'll kind of delve into as we go on. We'll also talk about a little bit about models and parameters. So essentially when we're looking at this, a model is going to be kind of this mathematical description of a kind of a simplified view. So we'll look at certain models that will look at things like, if we're implementing a new drug therapy for half of a sample versus not in the other one, that might be our new model that we're looking at. And again, so another example would be if you were to give a patient a drug and you were doing bioavailability studies and looking at pharmacokinetic parameters, the half-life here might actually be a parameter of this model, in which case the patient's metabolizing it. And then looking at probability versus statistics, we're going to look a little bit, some of this is going to kind of delve into the epidemiology, which will be kind of the second half of the course. But just looking at the difference between probability and statistics. With probability, this is kind of where we can take information that we have about a population and try to generalize it down to a specific sample, or say a specific patient. So say for instance, you have incidence data for, say, hypertension risk in the state of Florida, and then generalizing that down to your patient, whether or not they're going to be at risk for hypertension, right? Versus with statistics, this is where we're taking data from a sample and trying to generalize it back out to that population, okay? So one's going kind of more narrow to broad, one's going to go more broad to narrow. Does that make sense? So just be aware of some of the differences there between the probabilities versus actually doing statistics. Okay, so I'll give you guys a break now. We'll come back in 10 minutes and continue on.